Welcome back to Clinically Clear, guys. Today we'll be covering another short but important topic, that is deviated nasal septum, commonly referred to as DNS. Now, the prevalence of DNS can be even 1% of a given population. It can even be up to 80% of a given population. So it is a very common condition. Now let's look at the four etiological conditions or risk factors. Number one is trauma. As you can know, trauma can cause deviated nasal septum. Now, trauma can be laterally, it can be anteriorly, it can be during the birth. During the birth, when the baby is passing through the birth canal, because of the pressure, there can be trauma. Then, anterior trauma can lead to twisting of the cartilage, crushing of the cartilage, buckling of the cartilage, and even a fracture of the septal cartilage and the bone known as Jargeway fracture. Jargeway fracture. Lateral trauma can lead to a fracture known as Chevrolet fracture, or it can lead to dislocation of the septal cartilage from the vomerine groove. As we know, the septal cartilage, it goes and it sits in a vomerine groove. So trauma from laterally can lead to displacement of this septal cartilage from the vomerine groove. Septal cartilage is a quadrilateral shaped cartilage, so it is also known as quadrate cartilage. So first cause is trauma, birth canal pressure trauma, anterior trauma leading to crushing, buckling, twisting, or Jargeway fracture, lateral trauma leading to Chevrolet fracture or displacement of the septal cartilage from the vomerine groove. Next cause is developmental anomalies. See, now what happens normally, the septal process is there. No, the septal process comes from above. The two halves of the palate grow like this. So basically they fuse the two halves of the palate, and then the septal process, all three of them fuse during development, during embryogenesis. So basically what happens, any unequal growth or any abnormal development in these three processes can lead to deviated nasal septum. Example, let's say there's a cleft palate. So the two halves of the palate do not fuse. Now the septal process also has nothing to fuse. So the septal process deviates. That can be one reason. And another reason can be a high arched palate. This high arched palate, example, it is seen in adenoids where a child does a lot of mouth breathing. So because of a lot of mouth breathing, the palate is very arched. See, normally what happens, you can see here in green color, you have the two halves of the palate that fuse like this, and then the septal process that comes and fuses, making the septum straight. But let's say the palate gets highly arched, as in this red dotted line. So then the septal process has very less space to fuse. So it twists and fuses, so that, see, the length of the septal process is still the same, but because of the arching of the palate, it does not have space to stay straight, so it twists. So that can lead to deviated nasal septum. So these are developmental anomalies, any unequal growth, abnormal growth in the two halves of the palate, septal process, all that can lead to uh, deviated nasal septum. Example, cleft palate and high arched palate, which is seen in adenoids, children with adenoid. Then racial factors, more common in white people than black people, and genetic predisposition to DNS. That is also important. So four causes: trauma, anterior lateral or birth trauma, developmental anomalies, high arched palate, cleft palate, and more common in white people, and genetic predisposition. Next, coming to the types of DNS. Now, this diagram is more than enough. See, first type is anterior dislocation. The entire septum, as you can see in this purple line, has been dislocated towards one side. So when we look from below, the entire septum is dislocated towards one side. So because of that, what happens? It is known as anterior dislocation. So example is the cartilage getting displaced from vomerine groove. Let's say lateral trauma, and then the cartilage which is sitting in the vomerine groove, it gets displaced. So that can lead to anterior dislocation. That is one thing. Second thing is C-shaped obstruction. Whenever we think of DNS, we always think of C-shaped DNS. In C-shaped DNS, you have unilateral nasal obstruction because the septum, which is normally straight, is deviated towards one side. So unilateral nasal obstruction. But one thing we have to remember is, because of narrowing of one side of the nasal cavity, the other side is very wide. In this wide cavity, there is compensatory hypertrophy of turbinate. Very important. As you can see here, the turbinates are much bigger than what they are normally supposed to be. So on the narrower side, you have unilateral nasal obstruction, and on the wider side, you have compensatory turbinate hypertrophy in C-shaped deflection. S-shaped DNS is when you have, as you can see, it's obvious by the name, S-shape. Either the S-shape deflection can be in the sagittal plane, that is like that. When you see like that, it will look appear like that, or it can be in the anterior posterior plane, that is that way. So either it can be in the anterior posterior plane or the sagittal plane. So that is S-shaped deflection, and that will cause bilateral nasal obstruction. See, it's obstructing the nasal cavity on this side here and on this side on the below part also. So that is S-shaped deviation. Fourth type is nasal spur. Now, at the junction of the nasal bone, basically nasal bone and the septal cartilage, the bony cartilageous junction of the nasal septum, you can have a sharp projection known as nasal spur. This nasal spur obviously will cause unilateral nasal obstruction, as you can see. It can also impinge on a turbinate. It can go and press on the turbinate. This impingement on the turbinate, it can cause headache. This headache is known as Slugger's neuralgia or sphenopalatine ganglion neuralgia. Not only that, see, the septum also is covered by mucosa. Now, because of a sharp projection, the mucosa gets stretched. The blood vessels in this mucosa get stretched. So that can lead to bleeding and epistaxis. As I said in the epistaxis video, one of the anatomical causes is nasal spur. So that is one reason. Last type is bilateral thickening of the nasal septum, which can cause bilateral nasal obstruction. Example in septal hematoma, in septal abscess, in other causes where there is bilateral thickening of the nasal septum that can cause deviated nasal. That is also a type of deviated nasal septum. So anterior dislocation, C-shaped, S-shaped, and sharp nasal spur, and bilateral thickening of the nasal septum. These are the types of deviated nasal septum. Then symptoms. DNS is more common in males than in females. Now, because of nasal obstruction or stuffiness, it can be either unilateral or bilateral depending on the type of the DNS. You can have rhinolalia clausa, that is basically hyponasal voice. See, when I close one of my nostrils, my voice becomes hyponasal because of rhinolalia clausa, because that airflow on one side of the nasal cavity is blocked, right? That can lead to hyponasal voice known as rhinolalia clausa. Then anosmia, the airflow in the one side of the nasal cavity is reduced because of the obstruction. So the olfactory epithelium is not getting enough airflow. So reduced sense of smell. Anosmia, or actually more accurate would be hyposmia. Okay. Then because of the nasal obstruction, you have the mucociliary clearance is impaired. So you can have recurrent rhinitis, sinusitis, upper respiratory tract infections, otitis media, etc. One thing important is it can cause recurrent rhinosinusitis, but DNS cannot lead to sphenoid sinusitis. All types except sphenoid sinusitis, DNS can lead to. Then nasal spurs, and specifically I told it can lead to headache because of impingement on the turbinate, Slugger's neuralgia. It can cause epistaxis because of stretching of the blood vessels. Then, as I told, in C-shaped DNS, when the septum is deviated towards one side, on the opposite side you have turbinate hypertrophy. Now, this turbinate hypertrophy can actually lead to paradoxical nasal obstruction. Patient septum is deviated towards right side, let's say, but patient is feeling obstruction in the left side. That is because of the turbinate hypertrophy. That is paradoxical nasal obstruction. And remember, on the side of deviation, you can never ever have atrophy. There is nothing called as atrophy turbinate. There is only hypertrophy of turbinate. So these are all obstruction, unilateral. This is for first symptom is nasal obstruction, more common in males. Of course, DNS is more common in males. And then second symptom is paradoxical nasal obstruction. And the third symptom is if the DNS is very, very severe, you can have external deformity, cosmetic intolerance. You're looking at the nose itself being deformed because of very, very severe DNS. And if you want to see whether the nasal obstruction is at the level of the nasal valve, then you can do something known as Cotill's test, where you will pull the cheek laterally. If the DNS is at the level of nasal valve, then because of pulling the cheek laterally, the nasal valve widens, improving the airflow. Suddenly, the patient feels as if he or she is breathing better. So that is positive Cotill's test. So if it is positive Cotill's test and the patient has DNS, then the obstruction is at the level of nasal valve. Last, coming to treatment of DNS. Treatment of DNS, simple. If it is asymptomatic, very, very minor deviation, then don't treat it, just let it be. If it is a major case of deviated nasal septum, then you have to do surgical intervention. There are two main surgeries, submucosal resection and septoplasty. Septoplasty is preferred over SMR. I'll tell you why. Submucosal resection, main thing you need to remember is there is a lot of dissection, extensive dissection of bone, cartilage and septum. Bone and cartilage of septum. It is less conservative. Here, the entire bone and cartilage of the septum is removed except for the L strut. What is this L strut? The dorsal strut, just beneath the dorsum of the nose, a strut of cartilage, and the caudal strut right here at the columella strut of cartilage. Only an L strut is of cartilage is preserved. Rest all bone, cartilage, septum, everything is removed. That part of septum is removed completely. So it is less conservative. There's a lot of dissection. Whereas in septoplasty, it is more conservative. Very, very selective dissection. Only the deviated part of the nasal septum is repaired. How will you repair it? You can either hatch it out, you can do spurrectomy. If you want, you can remove the nasal spur, you can realign the nasal septum, etc. And if possible in septoplasty, you can even damage the cartilage. Any cartilage you can not damage, you can fix the cartilage. Any damaged cartilage, you can fix it externally and once again reintroduce it in between the flaps. So you'll make mucosal flaps, you'll see the cartilage in the bone, you'll remove the deviated part of cartilage. If possible, you'll fix it externally and you'll reintroduce it in between the flaps. So that is one more difference. And also, because you're removing a lot of cartilage and bone in SMR, submucosal resection, more risk of complications like tip depression. Basically, you're leaving only a small bit of cartilage, no? So there's not much support. So the tip of the nose can get depressed, leading to deformity. Less risk of complications in septoplasty. Submucosal resection, you cannot reoperate. You've removed the entire septum. Septoplasty, you can reoperate. And this is a very important point. In submucosal resection, you'll elevate both sides. On both sides, you'll elevate the mucoperichondrial and mucoperiosteal flap. Basically, what is it? See, nasal septum is also covered by mucosa on both sides. So, and beneath them, and septum meaning outermost layer of septal cartilage is perichondrium. Outermost layer of bony septum is periosteum. So mucus and the perichondrium, the mucoperichondrial flap. Mucus and the periosteum, mucoperiosteal flap. So only once you elevate that, you make an incision and you elevate that, you'll be able to see the bone and the septum. You'll be able to see the bone and the cartilage, right? So in SMR, you'll elevate the mucoperichondrial and the mucoperiosteal flaps on both the sides, whereas in septoplasty, only on one side, raised on one side. Sorry, this is a mistake. Raised only on one side. All right. So this is one more thing. Then, how will you elevate it? Using an instrument known as Freer's elevator. Not that important. Then, one more important thing is DNS surgery. Let's say submucosal resection. You should not do it before the age of 17. This is because at the nasal bone, etc., you have a lot of secondary ossification centers. These secondary ossification centers, they are not fully developed yet. So if I do a lot of surgical intervention, then they can get damaged, leading to facial deformity. It can interfere with the skeletal growth. So you should not do. But septoplasty, you can do it in children. If the deviation is very, very severe. Even septoplasty, we prefer to do it after the age of 17. But septoplasty, you have the provision to do it during childhood if possible. And the incision for submucosal resection is known as Killian's incision, which you will do it at the mucocutaneous junction. That is basically at the vestibule, you have the skin. Then behind that, you have the mucosa, basically 1 centimeter behind the columella. And just at the caudal end, at the columella, if I'm doing for septoplasty, it is known as hemitransfixian incision or Freer's incision. That you will do at the caudal end. 1 centimeter behind the above the caudal end or behind the caudal end is Killian's incision for septoplasty. For submucosal resection, I'm sorry. So that is the differences between submucosal resection and septoplasty. So the treatment, just these two surgeries are important. If asymptomatic, don't treat. That's it for DNS. Short topic, easy topic. Thank you for watching.